Hi, everyone, and welcome to the second day of the 2023 Focus on Eye Health Summit. Thank you for joining us today from locations across the U.S. and the world. I'm Todd, President and CEO of Prevent Blindness. We're pleased to bring you this event. And for those who may have missed yesterday or anyone who wants to revisit the presentations, day one videos and presentations can be accessed in the auditorium and are also available on our YouTube channel and the Summit section of our website. As I mentioned yesterday, for over a decade, this summit has brought together diverse stakeholders to explore vision from a public health perspective. This year's summit carries the theme, Why the Eye, serving as a reminder that the eye exists at the intersection of so many issues and should be consideration for health policy, community interventions, and economic considerations. I'd like to thank the many sponsors without whom this event would not be possible. Our platinum sponsors, the Alliance for Aging Research, Horizon, Pharma, and the SIVA Foundation. And our gold sponsors, Capellas, Bio, Bright Focus, the Center for Vision and Population Health, the National Center for Children's Vision and Eye Health, and Regeneron. And our many silver sponsors, all of which you can visit at the exhibit hall today, who have their own booths. We're so appreciative for everything that they bring to make this event happen. We encourage you to take full advantage of this virtual event by attending the presentations in the auditorium, browsing our on-demand video library, visiting sponsor booths in the exhibit hall, and engaging with other attendees through our chat feature. You'll find that many of our speakers today will be available for 30-minute video chats after their presentations to answer further questions. You can access these chats by going to the auditorium and clicking on the link in the session descriptions. This link will be provided during each speaker's presentation in the chat section as well. And for those of you with a competitive spirit, we have prizes available for those who most engage with the event throughout the platform. You can visit the leadership board for more details. A link to all presentations will be available on the Prevent Blindness website at preventblindness.org, where you can also access presentations from previous summits. Links to the Prevent Blindness social media accounts are available in the lounge. Please share this event on social media, and you can follow everything that is presented on Twitter at #iSummit. Today we'll have Q&A at the end of the sessions. You can submit your questions through the Q&A button at the bottom of the screen, and we'll respond to as many as time allows. And before we get into today's presentation, I want to make a pitch for in a campaign that we've recently kicked off, our Solar Eclipse in the Eye campaign. There are two major solar eclipses taking place in the US over the next 9 months. And it's super important that anyone watching these protect their eyes. We have so much information on our website about how to do so. You can also purchase your eyewear, your safety eyewear, through our website and our partners. So check that out, and you can visit the exhibit hall, find out more information. And now I invite you to sit back and enjoy today's presenters. Prevent Blindness has prioritized working on mental wellness and vision impairment by convening an interprofessional task force, releasing an issue brief last month around the key takeaways from the group, which you'll hear more about today. And now I would like to introduce our keynote speaker for this morning, Dr. Julian Eaton. Dr. Eaton is the Mental Health Director at CBM Global and an Assistant Professor at the London School of Hygiene and Tropical Medicine. We're excited to have him provide our keynote today on innovative mental health approaches. He'll discuss the importance of and share action steps for integrating mental health with the vision and eye health community. Again, if you have questions throughout, please submit using the Q&A button. And now, welcome, Dr. Eaton.
Thank you, Jeff. It's a great pleasure to be with you all today. My connection with this conference is both through working with an organization that has really pioneered eye work around the world for many years, CBM, but also because of connections with the world of mental health. Initially, I was contacted with this through a colleague at Harvard who I've worked with for many years. In fact, he was my predecessor here at the London School of Hygiene and Tropical Medicine, who was asked by Prevent Blindness to give an overview of what the connections are between mental health and eye care. Initially, that might seem like a slightly strange question, but I think the experience, particularly of the last couple of years around living through the COVID-19 pandemic, has really reminded us how important our emotions, our emotional well-being is to our everyday life. And we know very well, and our experience at CBM has been for a number of years, that for people with disabilities particularly, and also actually people who are marginalized for a variety of other reasons, there's an even higher risk of the kind of emotional trauma that comes about from those experiences. I'm a psychiatrist. I'm here in London now, but I lived for 15 years in West Africa, in Nigeria, and then in Togo. And I came to this world really thinking in quite a narrow way about mental health and mental illness. But I've had the great privilege of working with many different people across a range of different areas of work, but particularly in the area of blindness and in the area of disability. It's really taught me the importance of integrated approaches to support people's well-being. And this is what I really want to share with you today. So what are the connections between mental health and visual impairment and blindness? First of all, we know that people who have visual loss or who are blind have more mental health problems, if we do careful surveys, than people who don't. Now, of course, it varies enormously. And the research isn't actually that strong in this area because a lot of the studies are relatively small. But we know there is a connection. And anyone who's experienced visual loss, or who has a relative who has, or who works in a kind of clinical environment with people with visual loss, will know that to be the case. But we can't isolate our emotions from something that's happening to our visual system or our body or our sensory system. So we know that these conditions are more common, and we're usually talking about depression and anxiety and those kinds of issues. And we need to learn more to understand how we can support people who do have some mental health concerns associated with vision loss. We also know that the converse is true, that if we do something about that mental health problem that someone has, if we address it, if we support them, not only does that improve their quality of life, they feel better, they tend to function more and engage more in the community, but actually often their health outcomes are better as well. We have this connection between our mind and our body, which is completely integral. We cannot separate it. We also know that people who have mental health problems have more physical problems. So some people who have mental health problems, for example, not associated with disability, tend to express those through physical means. So we quite often see that in clinical practice in mental health, this intimate connection between mental health and our body. So why does it happen? How does it happen like that? Well, in my experience of working, particularly in services where we see people losing their vision, I really feel that it feels often like a grief reaction. It's a natural and understandable response to quite a profound change in your lifestyle. The ability to be completely self-sufficient without having to rely on other people. Sometimes it means a change in job or even loss of a job. And sometimes it means a change in your social role or your status within society. All of these things have a profound impact on our emotions. There are also some much more biological mechanisms associated with loss of sight and mental health. just having light coming into our eyes has an effect on emotion. We know that there are some mental health problems specifically associated with seasons, for example, that some people are more likely to have depression in the winter when there's less light, and the treatment for that is for people to have more exposure to light. So we know there are some biological connections between blindness and mental health as well. I don't want to give the impression, though, that this is all negative. Despite the fact that when there's a sudden change in our life, especially if we lose something that we value, if we're struggling to cope with these big changes in our lives, the main story that we see over and over again is of resilience. Is that the great majority of people, despite struggling with a loss of something that's very important to them, or having to make huge changes in their life, or learning lots of new skills and getting on with life in a different way, most people manage well. There is a tremendous level of resilience and capacity to cope with all sorts of adversity. And that's the big story. So of course there is this connection, but the big story is that most people, given the right support, are able to find new ways of living a rich life that enables them to thrive as well as they did before. Now, I've put up on the screen here what looks like quite a complex diagram, looking at all the different things that might affect someone's mental well-being if they have a disability. The conclusion of this nicely done piece of research is that actually the most important impact linking disability, of all sorts of disability, and mental distress is social exclusion. It's how we fit into society that often changes, especially with the onset of a new disability that's quite quick, that has the biggest impact on our emotion, because we're social beings. The way that we relate to people around us is the most important thing that protects our mental health. It defines us in quite a deep way. And so community is everything. And I'm going to be coming back to that later. Why does it matter? Why is it that there's been this huge increase in interest between mental health and various other sorts of health around the world, and particularly today, thinking about eye care? When we first started working, for example, in global public health, in HIV, or in child maternal health, or even more recently in the area of non-communicable diseases like diabetes, the focus was almost entirely on the physical things we had to do to get people better or to keep them physically well. We very quickly realized that unless you look at a person holistically, you don't get the same program outcomes that you need. So we need to understand the importance of how to do mental health well in these other physical care type programs, understanding how to support people with different conditions in order to be able to meet their needs properly, all of their needs. We know, as I said, that this also improves outcomes for those people. It's not good enough just to treat someone's diabetes and potentially prevent blindness or problems with the eye down the line. They're much more likely to take their diabetic medication well if they're not depressed. So you need to address that side of their life as well. And there's always politics in this. We need to be able to persuade the people who make decisions about investment in healthcare and social care services that it's worthwhile looking at the well-being side of people's lives and not just the surgery and not just the distribution of medicine for physical problems. The most important thing is that people are at the center of everything we do. We want people to thrive. We want people to do well, not to just manage, not to just have as little sight loss as possible, but to be able to have their job, to be able to have the relationships they want, to have the position in society that they used to have. That's why it matters. People are at the center of all of this, and we want them to thrive. I was asked to give a few examples of the kinds of work that we're doing in different parts of the world in bringing mental health into considerations of these other public health issues. How might that apply to the work that many of you do in eye care services or in supporting people who have vision loss? So I'm going to give a couple of examples, and I'm really looking forward to the Q&A and also to the half an hour that we have afterwards in a group chat to be able to discuss a bit more with you who have so much experience. The biggest lesson really that we've learned over a kind of 20-year history of a new exciting area called global mental health, applying good public health principles to how we do mental health, is that we can't work in silo. We can't just have separate mental health services. Well-being and protecting people's mental health fits into every element of health services, but also importantly into what happens in communities, what happens in other sectors like education, to enable people to live their best lives. So there are certain things that we can do in the community. There are things that can be well done in primary care. And there are things that need to be referred to specialist services. And it's the way that we make sure people are getting the best support from the different elements of this system that matters. I've put up on the screen here a pyramid, which is borrowed from the thinking around health systems that the WHO has about accessing care at different levels of a health system. The first example I want to give you of how we've been doing this in practice is in the whole area of neglected tropical diseases. I work here, where I'm sitting now, in a institution that was built around tropical diseases and understanding how they work better in low and middle income countries. And although that is a very long, very esteemed history, and the world of neglected tropical diseases has really become a very big and effective movement for eradicating a lot of these conditions, it's only really in the last 10 or so years that we've really started understanding how to integrate mental health into that work. And it has been a very exciting journey. I think we've made a profound difference to the programs that have adopted a more holistic approach to the well-being of people who are in those programs, adding to and complementing the excellent work they were already doing in the physical care of people. So I've put up here a paper that we published last year about mental health, stigma, and neglected tropical diseases, looking at the evidence that was available in this area. There was actually a surprising amount of evidence from a whole range of different programs around the world, but it hadn't really been brought together to help us understand how we could share that learning in different places. So I'm going to share a little bit of that learning with you. The key message really that came out of this review that we did, where we demonstrated the close link, the intimate link between stigma and discrimination. Remember, I said earlier that social exclusion is probably the most important factor driving mental health problems. How people become less able to participate in the community as a response. That mental distress arrives from that, and that can sometimes lead to mental health problems, mental health conditions. And then people don't access care so much, and they end up doing worse in their physical care as well. And the learning from the research was that, first of all, although as health services, as health systems, we've tended not to include mental health, people really want it included. It's a priority for people affected by all sorts of health problems and disabilities. And we need to be responsive to people's needs. That people preferred the mental health support and should be part of comprehensive programming, not as a separate siloed program that they have to go separately to be referred to. And that if you don't address mental health problems, it ends up with you have a negative impact on the outcomes you want to achieve with people's recovery. And in this cycle that I've described, there are various different places where we can intervene effectively, where there's good evidence-based interventions. There's a couple of key things that we have really drawn out of this work and are starting to practically apply to the work that we're doing in both eye care and in integration of mental health into neglected tropical diseases work. Firstly, people, especially in very poor areas, but actually almost everywhere in the world, don't want to go to multiple different services to receive their care. It has to be person-centered. So we need to integrate a good understanding of mental health into frontline services. These are skills that everyone should have at a basic level. Clinicians who are seeing people, the person at reception, the person who does the subsequent support if someone needs it after any health interventions they've had. Basic empathic skills, good communication, being able to listen to someone and to give thoughtful, considered advice. But the most important thing is to be able to listen. We don't need psychiatrists everywhere in systems and services, but what we do need is a workforce that is thoughtful about the emotional needs of the people who come to see them. And that results in much more satisfied customers. And actually, my experience is having taught frontline health workers, whether they're surgeons or general nurses or other people, they enjoy their work more if they feel they can also attend to the emotional needs of people and not just rely on their skills and physical needs that people have, and then don't know what to do when someone starts crying in front of them or expresses some level of distress. We also need to make sure that we start learning how to find the local mental health services that are available so that we can refer people when appropriate. We need to recognize that people aren't individuals and isolated people, that they live within families. They have caregivers. And this is particularly important for children. And I've put up a lovely picture here from one of our programs in northern Nigeria of a mother with a small child. We all rely on the people around us. We learned that during COVID-19. We are people who require people to support us, but that's particularly important when we're working with children. And of course, we need to recognize that caregivers have their own emotional needs. They're often put under a lot of stress. And some of you listening to this will be caregivers, and you're aware of that sometimes the attention isn't given to your needs and your emotional needs particularly. We also need to think about the way the world, more broadly, the community treats people. We've heard many, many times of people who've had good health interventions. They go home either recovered or much better, much more stable, but they continue to be excluded. They still find it difficult to marry. They still find it difficult to get a job because of stigma. So we need to think about the world in which people live and not just the treatment that they get. I'm going to quickly go through some of the different ways that we've found we can provide this kind of holistic support at different levels of the healthcare system. I'm very conscious that I'm talking to people from all around the world and lots of people in the USA. These are quite different places to where I usually work, which is in sub-Saharan Africa or other very poor countries in the world. But one of the things that we're learning in public global health is that many of the lessons available in low-income countries, resource-poor settings, apply very well in high-income countries as well. And I'll show you an example of that in a minute. We're all people. We're all people with emotional needs. We're all people who live in parts of communities, whatever country we're in. There are many, many things that we can learn across countries. So first of all, at the community level, we can do that work of trying to reduce stigma, try to make it easier for people to be integrated into communities. Sometimes that's going to see an employer and saying, will you please employ this person with a disability? You might not have considered it, but they could actually do the job just as well as anyone else. Sometimes it's talking in church groups or in youth groups to change attitudes towards people who otherwise feel quite excluded and isolated. Sometimes there are practical health promotion activities going on, and sometimes people can be well linked to peer support groups, which is very helpful for people. This is a picture of a colleague of mine, Dixon Chibanda, there in the middle, who's sitting on what's called a friendship bench. And this is in Zimbabwe. And the friendship bench is a place which, when it started, would be usually near a health center. And Dixon trained lots of grandmothers in communities who are respected by their communities, who had natural skills in giving advice and supporting people. And he trained them to be able to provide support on these benches next to these clinics in Zimbabwe. Now, it's been incredibly successful, so much so that the friendship bench is now being used in several high-income countries, including in New York City, for example. So communities are important to come around people and support them when they're having difficulties. Apart from the community, we also need to recognize that that individual can be helped in certain ways. It's always good to identify people early, whether for the physical needs they have or recognizing that they have emotional needs. We need to give those frontline workers the skills to recognize an emotional need and not just ignore it. I'm sure we've all experienced that, where someone starts crying or someone starts talking about how hard they're finding it. And a very hard-pressed clinician who knows they've only got 5 minutes essentially ignores that cry for help to go on to talk about the physical needs of that person because they don't know how to respond. So we need to be able to pick up emotional needs and get the treatment and support that those people need. We know very well that the people who really understand the experience of disability or of vision loss are other people who've been through the same experience. Sometimes people who are a bit older, more mature, have got more life experience to share. And we really are increasingly recognizing the value of peer support, of placing other people with disabilities, with different health problems, as key partners in recovery journeys of other people, sometimes people who are just starting out on that recovery journey. And this, for me, is the most revolutionary thing we're doing, is turning around the idea that professionals have all the answers, but recognizing actually that other people with the same experience have many of the answers to support their peers. And then finally, and if anything, I would say probably the least important of the areas that I'm talking about is making sure that the very small number of people who can't be helped at the earlier stages of the kind of support I'm talking about in their communities with peers by having their carers supported as well, can be referred and should be referred to mental health care. For example, if they're talking about life not being worth living anymore, if they're in the depths of despair, then they need to be referred to people who can help them. And many of the exciting developments in my field have been helping that mental health care to be available at primary care level in very poor countries, which has never happened before. I mentioned politics earlier, and all of this excellent work, all of the really good research that we've been doing will be much more valuable if people who have resources to invest in support pick up these good practices and make sure that they're available for as many people as possible. We found that bringing mental health into the wider world of neglected tropical diseases, for example, has been incredibly effective because we had some champions who worked with us to bring this forward, people who were already respected within that world. We had to get good evidence, which we worked very closely with the World Health Organization to put into practical guidance. With WHO endorsement, governments take that much more seriously. And there are some really good practical guides now for integrating mental health into neglected tropical diseases. I wanted to give the example of Vision 2020 really as being an early example of a whole community of people with common interests coming together to paint a bigger picture, to work collaboratively towards a really big, ambitious target. It was a wonderful example, and I was privileged to have watched that in the early years of my career. We also know that as much as we do, it's often other things in the outside world that are happening that we can just capitalize on. I mentioned COVID-19 earlier. COVID-19 was a time when many people struggled with the emotional consequences of a pandemic, of a physical disease. But it raised the profile of emotional needs in all sorts of places, in very high levels of politics, in health service planning, and subsequent to COVID-19, we've really seen much more of an openness to thinking about emotional needs alongside physical needs of people. We can build on that. We can capitalize on that. Thank you for listening. I hope that's been of use to those of you who are in all sorts of different places in this particular field. I have valued so much the learning I've had from the eye care community and from the wider community of people working in disability and inclusion globally. It's informed how I think about mental health. And I'm constantly trying to see if we can do a better job of linking those areas together to recognize people within the whole emotional complexity at the center of everything we do. Thank you.
Thank you. Thank you, Dr. Eaton. That was really terrific. I recently was privileged to be able to join colleagues from all over the globe working in vision and eye health for an international meeting. And I find it really fascinating to learn what folks are doing all across the country. And while certainly I find a lot of things different that we're doing here in the US, it's really an eye-opener on how much similarity there is, whether you're in a small village in Zimbabwe or a large city in the US. There's so much commonality. But we do have a lot of questions here I want to get into for you. Let's see here. This is an interesting one. You know, when people are depressed, I think this is across disease conditions, but when people are depressed, they tend to not take as care of themselves necessarily. And so many diseases such as diabetes need constant care. How can we work with people who are experiencing mental health challenges to understand the importance of continuing to focus on their physical health at the same time?
So I think the two are intimately linked, and I think you can address both. So it's very well evidenced. The strongest evidence is probably in diabetes and other conditions that need long-term care, but also similarly in TB, where you have a very long regime of antibiotics, or in HIV, where you need to carry on taking medication. That those needs of continuing to look after yourself really get compromised where people are depressed. I think the important thing is not to try to just push harder and harder and harder to persuade people they need to do something in terms of their physical health, but acknowledge what's under that. Is to say, why is it, do you think, that you're not doing what you know is going to help you? Because those of us who aren't in that situation, we're not feeling depressed, we can't understand why they're not doing it. And it's not because they don't understand that it's much better to have close control of your glucose levels to have better long-term outcomes. It's because of the self-worth that goes down, the self-esteem that goes down with depression. So acknowledging that there's a mental health issue, getting alongside people to address that. And a lot of that is social. A lot of it is understanding that someone might feel quite lonely or isolated, or they're still going through that grief of a big change in their life that they're having to cope with, and supporting them, if necessary, to then go to the specialist care that they might need to address that. That's how the physical side will improve, is by acknowledging and addressing the mental health side. Sometimes acknowledging is almost all you need to do, is actually seeing someone as a person who's suffering and being alongside them. You're 90% of the way there.
Thank you. This question kind of aligns with that a little bit. Obviously, one of our goals is to in vision health is to reduce vision impairments, slow vision impairments, but often that can't be done. There are no medical interventions. So how do we work with people who may be experiencing vision loss for life?
Yeah, this is a really important question. And I think something that has turned around the way that we're thinking about this in CBM. Historically, we would also be doing what we could in health services to try to prevent blindness or prevent vision loss. But quite tragically, what would often happen at the end of that journey, where there's nothing else medical to do, people would effectively be told, I'm sorry, there's nothing for you. And of course, that's very far from true. What people mean is, medically speaking. But we should be thinking well beyond just medically speaking, and actually saying to people, but you can have a full and rich life. And this is how we're going to help you to do that. We're going to work with your family. We're going to look at maybe you having to have a career change. We're going to be looking at the assets that you have that you can bring to the fore. We're going to help you learn how to live as good a life as you had before without the same vision as you had before. That's a very different message. And I think often the kind of golden bullet in all of this is peers, is people, especially if it's a very young person, for example, who can only see despair, because actually that's the message they get from the majority world is you've lost something. But actually other people, maybe who already have vision loss, who are living very full and productive lives, being mentors, being alongside them, helping them to recognize that that's not the only way it could go, is immensely powerful, and something that we should be building into how we do things. And we should never again in health services say to people, there's nothing that can be done. We should be saying, here's the people who can help you. And often that might not be inside the hospital. It might be an NGO. It might be a peer support group. But we should never be allowing ourselves to give people that hopeless message.
And I think sometimes it may not necessarily be the answer they're hoping to hear, but if delivered right, at least it's providing them hope that, maybe we're not going to be able to go here, but we can go here instead.
Yeah.
In this situation. You mentioned the stigma associated with mental health a couple of times, and I think you're right. I think some of that has started, COVID-19, one of the good things that may have come out of that is to start to broaden the understanding of mental health and mental wellness. But are there any thoughts you have to share with any of the viewers of this webinar on ways that we can continue to work together to eliminate some of that stigma or reduce it?
Well, the learning about stigma has really grown substantially in recent years. When I first started this work, we did a lot of awareness raising, which was really based on the idea, which turns out to be not very true, that if you give people enough knowledge about something, then it would change their attitudes and their behaviors. So we would spend a long time saying to people, schizophrenia is an illness like any other, and you shouldn't exclude people, or epilepsy is treatable, and people can live productive lives. It's not very effective because people's attitudes are much more profoundly held than just the knowledge that they're taught. And what actually makes a difference is an emotional connection. So the best evidence around changing stigmatizing attitudes, not only to people with mental health problems, actually, but also to people who are blind or to people with different disabilities, is helping people to see beyond the stereotype, to see beyond the label that's sitting on that person, to understand there's a human being there, that actually this is a father, it's a teacher, it's a person who is a bit like me in many ways, actually, and making that connection. So contact interventions is the buzzword. If we can help a community to make that emotional connection with a person, especially if they feel there's a familiarity, there's a commonality between them. That's what really changes attitudes and behavior and reduces stigma. And it does work. There's very good large-scale studies at kind of national population level over a period of time. You can change attitudes in that way of making connections. Sometimes it's actually through video and those kind of much more mass, scales, but it works.
Are we back, Julian?
Yes, I've got you back now.
Okay, apologies
Sorry
for
about
that. I think there was a hiccup there.
Okay.
I'm not sure exactly where we were, but here's another question. I know we only have another minute or two left, but you spoke a bit about the importance of acknowledgement, and I certainly know from our work, I can think of several patients, in fact, that we've worked with who have hidden their own vision challenges, and I think often we hear that, especially where it's not visibly recognizable. But that's certainly the case with mental health as well. How can we work to, I guess it goes along with that stigma question, but of encouraging people to be open and acknowledging their problems, or at least with them within themselves and their loved ones?
Yeah, I think this is one of the other things that's changing in the positive direction in the way that society is increasingly talking about well-being, is increasingly acknowledging mental health problems. Historically, I think it was always seen as weakness. Men never talked about their emotions. And there's an association always with the kind of very severe end of mental conditions with very bizarre behavior, and it was a kind of joke in the playground. I think that's really changing now. And I think it's something that helps us to have that conversation with people, especially if it's a friend or a relative. Of course, a health professional can also do so, but to say, do you think there's a problem? Do you think it's something that we could maybe work together on? And carry people through that journey of acknowledgement. I think challenge doesn't often help very much. People tend to retreat into kind of defensive mode. But I think working alongside someone and actually normalizing it, it's quite understandable that you're feeling shell-shocked by the experience you've just been through. Let's see that as a part of what's going to help you as well as the healthcare that you're going to have to have.
Yeah, thank you for that, and it does look like we're at time. So, first of all, thank you, Dr. Eaton, for taking some time today to spend with us.